This video is about cervical radiculopathy. It is spinal nerve root dysfunction which causes dermatomal pain and paresthesias, myotomal weakness, and impaired DTRs. It means there is sensory and motor both involvement. What are the causes of cervical radiculopathy? Basically, it is caused by the compression of spinal nerve root caused by disc herniation, cervical spondylosis, or extraspinal compressive radiculopathies. Most commonly, it is caused by herniation of intervertebral disc, which may be caused by degenerative processes or trauma. It could be centrally or laterally. Central disc herniations compress the cervical cord directly, while the lateral disc herniations result in the compression of cervical nerve root. Examination involves the dermatomal testing, myotomal testing, and some special tests. These are the classic patterns: C5, C6, C7, C8. C5 motor involvement, deltoid, elbow flexion, sensory, lateral arm, reflex biceps. If there is involvement of the C5 nerve root in cervical radiculopathy, then the patient is unable to perform the deltoid muscle action and the elbow flexion, and patient will feel the sensory involvement in the lateral arm, and the reflex that will affect will be the biceps. C6 in C6 involvement, wrist extension and the bicep will be affected, and sensory involvement will be the lateral forearm, thumb. Reflex that will be affected will be the brachioradialis. In the C7 involvement, motor involvement will be of the tricep muscle, and it will affect the wrist flexion and all the tricep section. And sensory involvement with the dorsal forearm and long finger. Tricep reflex will be affected. In the C8 nerve root involvement, the motor involvement is basically of the finger flexors. The actions of the finger flexor will be affected, while the sensory involvement involves the medial forearm and the ulnar digits. And neither of any reflex will be affected in the C8 involvement. And the pain distribution is like if there is involvement of C5, the pain will be in neck, shoulder, lateral arm. If there is involvement of C6, the pain will be in neck, dorsal lateral arm, thumb. If there is involvement of the C7, there is a pain in neck, dorsal lateral forearm, and middle finger. If there is involvement of C8, there is a pain in the neck, medial forearm, ulnar digits. The clinical test for diagnosis. First of all, the Sperling test, also known as foraminal compression test, neck compression test, and quadrant test. It involves neck extension, rotation, and downward pressure on head. Therapist will stand behind the patient, and the patient is in sitting position. Therapist will bring the patient neck in extension, rotation, and will apply downward pressure on head. The positive finding elicits the production of the radicular pain into the ipsilateral arm of head rotation. Second of the test is shoulder abduction test, or shoulder abduction relief sign, or Beckord's sign. It involves active the passive abduction of ipsilateral shoulder, and due to at the end of the result, relief of the radicular symptoms, and the take stretch off the affected nerve root and may decrease or relieve the radicular symptoms. Baki cervical spine tests, neck distraction test, manual traction test. It will also relieve the symptoms. Lhermitte sign, Barber chair phenomena, flexion of the neck producing electrical shock-like sensations that extend down the spine, shoot into the limbs, and indicates the spinal canal stenosis, disc impingement, multiple sclerosis tumor. Anterior doorbell sign, it indicates the nerve root tension radiculopathy. Deep palpation, our C5 segment produces pain in superior scapulovertebral border that radiates to upper limb. Others, Nefziger's test involves Silva manual. Nefziger test involves the manual compression of jugular vein bilaterally, and increased regulation of the pain or sensory disturbance over the distribution of involved nerve root confirms the presence of an extruded intervertebral disc or other mass. Valsalva manual involves a deep breath and hold it while attempting to exhale for 2 to 3 seconds. Positive response involves the reproduction of symptoms. The pushing increases the intrathecal or intraspinal pressure, revealing the presence of the space occupying mass, such as an extruded intervertebral disc or narrowing due to osteophytes. Hoffman signs, upper motor neuron sign, indicating the pyramidal tract involvement and indicates the myelopathy. Diagnosis could also be done by plain radiographs, MRI, cervical myelogram plus CT. Plain radiographs could show the narrowing of the neuroforamina secondary to the degenerative changes, and MRI could detect the significant soft tissue pathology, disc herniation. Cervical myelogram could outline the exiting nerve roots with radiopaque dye, and visualization of the nerves in relation to surrounding osseous structures is possible with cervical myelogram. Electrodiagnosis plays a critical role. They refer to an extension of the neurological examination as it is able to provide the physiological evidence of nerve dysfunction. It involves EMG, it involves the second motor and sensory nerve root conduction studies, and third, late responses. Treatment involves mobilization, traction, pharmacological management, spinal manipulation, epidural steroid injections, and surgery. Immobilization. Some advocate a short course 1 week of the neck immobilization may reduce the symptoms in inflammatory phase. Immobilization can be done with cervical collar. Cervical collar has not been proven to alter the course or intensity of the disease process, but it could be helpful. Traction. This is the traction. This traction restricts the neural foramen and decompresses the nerve root. Typically 8 to 12 pounds of traction at approximately 24 degrees of flexion for 15 to 20 minutes interval. Most beneficial when acute muscular pain has subsided. Not be used in patients who have signs of myelopathy. Physical therapy. It involves a graduated physical therapy program restoring ROM and overall conditioning of neck musculature. As the pains improve, gradual isometric strengthening program, active ROM and resistive exercises as tolerated could be included. Pharmacological management involves NSAIDs that have effect on the pain and inflammation in general. 10 to 14 days of regular dosing is all that is needed to control pain and inflammation. Oral steroids that reduce associated inflammation from compression. Tricyclic antidepressant controlling radicular pain caused by depression. Opioid medications generally not necessary for pain relief. Spinal manipulative therapy and mobilization described by external force applied to the patient by the hand, an instrumental device or furniture, resulting in the movement or separation of the joint articular surfaces with high or low velocity of the joint movement. Epidural steroid injection. Its principal steroid decreases pain and inflammation. At the site decreases prostaglandins. Indication: radicular pain unresponsive to non-intervertebral care for 1 to 2 months. Patient without progressive neurological deficit or cervical myelopathy can be considered before surgery. And there are a lot of complications regarding that: dural puncture, vasovagal reaction, facial flushing, fever, etc. Surgery. There are some red flags for surgery. In these cases, surgery is necessary. Persistent or recurrent radicular symptoms unresponsive to non-operative management for at least 6 weeks. Disabling motor weakness of 6 weeks duration or less, that is deltoid palsy. Dystroph, progressive neurological deficit, static neurological deficit, plus radicular or rapid pain, instability or deformity of functional spinal unit, plus radicular symptoms. Surgery could be posterior laminoforaminotomy, anterior cervical discectomy and FUN, anterior cervical discectomy without FUN, cervical disc arthroplasty. I hope you liked the video.